On episode 267 of the 40 Plus Fitness Podcast, we meet Dr. N Cohn and discuss his book, Cardiovascular Health, How Conventional Wisdom is Failing Us. You can find the full show notes for this episode at 40plusfitnesspodcast.com/267. Have you decided you're ready to make a change? To reclaim your health and fitness? The 40 Plus Fitness Podcast is here for you. I'm your host, Alan Meisner. I'm an NSAM certified personal trainer with a specialization in corrective exercise and fitness nutrition. Let me be your coach as you find your way on your health and fitness journey. All right, let's go. Hey, thank you so much for being a part of 40 Plus Fitness. I really appreciate your diligent listening each week. And do hope, again, as I try, to bring you the best guests and the best information I possibly can in health and fitness. I do hope that you're taking these tips and things that you're learning and putting them into practice. Something you learn is only valuable if you're actually applying it in your life in a positive way. So I do hope that you'll take the lessons, particularly some of them that we go through today, and will apply them to your life. I'm really excited about the guest today, but before we really get to Dr. Cohn, I did want to give you an update on my shoulder. We looked at the MRI results, and I do have a tear on my rotator cuff, so I am scheduled to go in for surgery on that. Because of my recording schedule and everything, I probably won't be able to tell you next week exactly how that surgery went, but I will on Facebook. I will probably do some posting on Facebook when I'm able. So if you'll go over and join the Facebook group, you can go to 40plusfitnesspodcast.com/group, and you can join the Facebook group, and I'll let you know a little bit about what's going on over there. I do appreciate the well wishes from folks with the group that have told me, they hope that I'm doing all right, and particularly the advice. So thank you guys so much for being a part of this journey, for helping me kind of get through this period. I'm a little bummed that I'm not going to be able to lift weights for a little while. But that's life. I've got to adapt, and I'll put some different goals on the table for the next 3 months and start working on those. But I am going in for surgery soon, and I'll let you know how that comes out. Just go to the Facebook group at 40plusfitnesspodcast.com/group. So our guest today is Dr. N Cohn, and Dr. Cohn has so much experience in cardiovascular health. He is a professor at the University of Minnesota, and he sits on, he's been a sitting president on several of the societies associated with heart and heart disease and health, and has written numerous papers. I mean, over 750 articles and papers on heart health, and he is the editor of the cardiovascular medicine textbook. So, I mean, this guy knows this soup to nuts. It's a really interesting conversation. I think you're going to learn a lot today. With about half of us are going to suffer from some form of heart disease in our lives. And so if it's not you, it's somebody you know. And as you know on here, the more you know about health and the more you're able to apply in your life and in the lives of others, the better off we're all going to be. So with no further ado, here's Dr. Cohn. So Dr. Cohn, welcome to 40 Plus Fitness.
Thank you. It's a pleasure to join you.
As a 51-year-old male, cardiovascular disease is kind of one of those things that's a lot more top of mind than it has been in a lot of periods of my life. As I hear, more and more the statistics of people that are affected by cardiovascular disease, it's really a little frightening. So I was very glad to find a book like yours and to be able to kind of get into the topic, because you've taken what I would consider a very complex science-based information, and you've really put it down into something that's succinct and easy to digest. And so I felt like I really was getting an education while I went through your book, but it was a pleasurable read because, it wasn't just so deep that I would get lost. So I really appreciate how you put this book together.
Well, I appreciate your comments about it. It has been a labor of love to try to get the message across to the public that, as you say, you should be afraid of cardiovascular disease, because more than half of American adults will die from a cardiovascular morbid event. That's what we call it. That means heart attack, stroke, heart failure, sudden death. These are all cardiovascular morbid events. And more than half the population will die from them, but yet not everyone is as insightful as you are and is scared about it. They should be scared about it. They always seem to be more scared about cancer than they are about heart disease for reasons I don't fully understand, because cancer is less frequent than cardiovascular disease, and the ability to prevent cardiovascular disease is far more obvious than the ability to prevent cancer. So there's a lot of things that one can do to protect oneself from cardiovascular disease, and early detection is, in my view, one of the most important factors, but yet we focus early detection on cancer, not on cardiovascular disease. So I think there's an important message here that the public has to understand.
Yeah, and I think one of the things that, I guess, again, when I was younger, I know you kind of put this as the conventional wisdom, is that, one day you're going to potentially get cardiovascular disease. But as you kind of highlight in the book, cardiovascular disease is really a progressive thing that's happening our entire lives. Could you kind of go into that process of how we develop cardiovascular disease and exactly what it is?
Yes, well, the cardiovascular disease means disease affecting the arteries that provide nourishment to all the organs of your body, and the function of the heart itself, the pumping chamber, which provides that blood flow to all the arteries of the body. That's cardiovascular disease, and every organ is dependent on that blood supply coming from the pumping of the heart and the delivery of the blood by the arteries. And it is true that these organs age as we age, so the blood vessels and the heart lose some of their flexibility, lose some of their capacity to function as we get older, and the rate at which that occurs is very dependent on your genetic background. The media and all of our health agencies so stress the role of diet and exercise as if that's the whole cause of heart disease, and that's not true. The Egyptians eons ago died with cardiovascular disease. It isn't something that's occurred because we stopped exercising and we're eating a lot of fat. That's not true. The inheritance is a very important factor, and the rate of aging of the arteries in the heart is critical to when one will have a cardiovascular morbid event. Our view, my view, and the view in my program at the University of Minnesota is that we should be able to keep every person healthy from cardiovascular disease through the age of 100. And at the age of 100, I think we can look back and say, now that's probably you've had a good life, and now pretty much you're at the mercy of your organ failure, which will begin to take place. And if we can keep you healthy until age 100, I think we'll have a very happy and fortunate population. So that's really our goal. We want to slow the aging process so that people can reach age 100 without having suffered a cardiovascular event.
Okay. And like I said, I did really appreciate the kind of some of the science that was in this, even though, again, like I said, you made it very easy to get through. And it's probably the first time I've really understood the purpose of the endothelium. I'm sorry, I said that wrong. Endothelium and nitric oxide. I know when I was in my 40s, early 40s, I had an event where I actually, it's called water poisoning, but I had a convulsion. And later that evening, I was sitting. I didn't go to the doctor right then. I said, okay, I'm just going to go home and rest. And later that evening, I was sitting there, and my chest was hurting, and I felt really bad. And I thought, maybe what I had earlier today was a heart attack. And I went into the emergency room, and of course, one of the first things they do, they rush you to the back as soon as you say chest pains, heart attack. But then they gave me the nitroglycerin. And so, at that point, I'm like, okay, I understand they give you that to do something, but I think after reading your book, I now actually understand why they do that. But could you kind of go into the endothelium, nitric oxide, what that does for our arteries, and then some of the things, like smoking, inflammation, diabetes, and whatnot, that would cause problems with the function of the endothelium?
Yeah, well, that's a very important element that we've only learned about in the last decade or two. And the endothelium is the inner lining of the arteries that affects every artery in your body, including the little microscopic capillaries that, of course, we can't see, but nourish our tissues. And that inner lining of those little arteries secretes a substance called nitric oxide, which is actually a gas as it's secreted. And that gas protects the inner lining of the artery from clotting, which causes heart attacks and strokes, from damage to the underlying artery wall, and from invasion of the artery wall with cholesterol, which leads to plaque formation that obstructs the arteries. So the endothelium is a very important structure. And what damages the endothelium? Well, aging certainly has an adverse effect, and the rate at which aging occurs is largely genetically determined. But one thing that will really accelerate aging is smoking. Smoking has a very serious adverse effect on that inner lining and impairs the release of nitric oxide. And the nitric oxide is what's protecting the wall from the clot formation and protecting from cholesterol invading the wall and getting underneath the wall where it'll start obstructing blood supply. So that is also influenced by inflammatory diseases. And when I say that, these are chronic conditions that some people have, like arthritis and various rheumatic diseases, HIV, even some of the treatment for HIV will adversely affect the endothelium. Cancer chemotherapy adversely affects the endothelium, and all these things will accelerate the aging process in the arteries and the aging process in the pumping chamber of the heart that will eventuate in these morbid events. So if you know you have endothelial dysfunction, is what we call it, that the endothelium is not as healthy as we'd like it to be, what do you do about it? Well, you can hopefully alter your lifestyle, which particularly stopping smoking would be a major factor. But those are very minor treatments. The most important thing is to understand what's happened to you and be placed on drug therapy, which protects the endothelium. And that's true of a number of drugs that we use to treat cholesterol and treat blood pressure. They protect the artery wall more than lowering the blood pressure and lowering the cholesterol. And those drugs have a profoundly favorable effect on the rate of aging. So knowing who needs to be on these treatments is really the critical factor. And that's where identifying the early disease, which I emphasize in the book, is such an important factor in identifying who needs to be treated, in choosing the treatment that one takes, and in basically slowing the progression of disease so that you can reach age 100 without a morbid event. That's our goal.
Okay. Now, when we talk about diseases like, typically talk about diseases like obesity or diabetes, a lot of times we're talking about the food, and there's a lot of conversation about, eating an anti-inflammatory diet, making sure that you're maintaining the right balance so that you're not gaining weight. And in many cases, we could all probably afford to lose a few pounds if we've really looked at it. And so you said in the book, you set up some basic dietary rules. Do you mind going through what you would feel for heart health on cardiovascular health, what would be a good eating program?
Well, what I emphasize in the book is the fact that eating habits are probably less important than how much you eat, that avoiding obesity is probably the most important thing one can do. But the bad news, Alan, is that all the efforts to document that changing diet and changing exercise will favorably affect longevity or favorably affect the incidence of heart attacks and strokes, these efforts have all failed. So I am inclined to at least raise the possibility that the relationship between obesity and dying early, which is clearly present, there is no question that fat people die sooner than thin people. But taking a fat person and working with that person to get them to be thin has not been rewarded by any evidence that we have cut down on the risk of having heart attacks and strokes. I'd like to believe that it would if we did a big enough study and were effective enough in getting people to follow instructions, but it hasn't come to pass yet. And I'm of the inclination that it is the genetics which leads people to become fat, which is the evil factor, not the fatness itself. So even a person destined for obesity because of their genetic makeup, even if they avoid getting fat by altering their diet, they may still suffer from the accelerated aging of their arteries that we think we should associate with obesity, but maybe should be identified as a genetic factor, not as an environmental one.
Okay. Now, I've struggled with higher cholesterol. The interesting thing is that my triglycerides are very, very low. My HDL is really high. And my LDL would be classed as high. And so putting it all together, I obviously have high cholesterol. And I've tried statins and just have zero tolerance for them at all. They just completely break me down to a point where I can't function as a human. Now, there's a new drug out, and I didn't put this in the notes for us to talk about, but it's called Respera, I believe.
Yeah.
My doctors talked about it. Now, you had said in the book that it really, there's not enough evidence right now to say that it reduces the more morbid events of a cardiovascular disease. But could you kind of talk just a little bit about the medication? Because I think that's really, when you look at the emphasis of your book is once we know that we're in that line of fire for cardiovascular disease, sometimes going ahead and getting on a preventative medicine is going to help us. Could you kind of talk a little bit about the medications that are available and how we can manage this?
Yes, let me address that, because you raise a very important series of questions here that are important to understand. We have traditionally looked at cholesterol as a risk factor, and that high cholesterol is the evil, and the goal is to lower the high LDL cholesterol, which is the bad component of cholesterol, LDL. As you point out, the HDL, which is high-density lipoprotein, high-density cholesterol, is actually protective. So there has been the general sense that if your HDL is high, you're protected. If your LDL is high, you are at risk. And that what we should be doing is keeping your LDL cholesterol down as the major factor in preventing heart attacks and strokes. The problem with that simple idea is that when you look at a whole large population of people who have had a heart attack or stroke, you find that the LDL cholesterol in those people who've had that event is pretty much the same as the LDL cholesterol in people who have not had a heart attack or stroke. So that the elevated LDL is not really a major factor in causing the problem. The elevated LDL needs to be reduced in order to protect the artery from aging, but only in those people who have abnormal aging of their blood vessels. Otherwise, if your blood vessels are healthy, your LDL does not need to be treated. So I kind of look at it as if there's the wall of the artery and that endothelium we talked about has a gate protecting it from invasion from bad things like cholesterol. And it is the gate that's up or down rather than the level of the cholesterol, which determines whether there's going to be invasion of the artery wall with cholesterol plaques that will lead to heart attacks and strokes. So the issue is not the level of the LDL as much as it is the presence of that gate to keep the cholesterol from invading the wall. Now, these new drugs, there is lots of concern about taking statin drugs, and we hear this all the time. Interestingly, if you go to a medical audience and ask how many doctors are taking statin drugs, almost everyone puts his or her hand up. So doctors recognize the virtue of keeping the gate down or the LDL level down. And the public has been more in tune with the adverse effects of these drugs and begins to not want to take them. And so many of my patients begin by telling me they don't want to take a statin drug. Do I have to take one? And of course, they don't have to take one if their arteries are healthy, but if I find evidence for early disease in the arteries, I encourage them to take them. Now, are there people who can't tolerate them? Absolutely. You may be one of them, Alan, who can, but it is a relatively small number, a very small percentage of the population, because most of the doctors that we see are taking them. So they are not really any different than you and I. They have the same risks and same benefits, and they're oriented toward taking the drug. Not much of the public is not. Now, these new drugs, which are very expensive and are injectable, so they have to be injected, are profoundly effective in lowering the cholesterol level. But we're still not quite certain how effective they are in preventing morbid events. My view is that the statin drugs are doing much more than lowering cholesterol. They're keeping the gate down and not allowing the artery wall to be invaded by plaques. That may be partly related to lowering cholesterol, but is importantly related to other effects of the drug, these statin drugs. Do these new drugs, these new expensive drugs, which don't have the side effect profile of statins, so they are tolerated usually by people who can't tolerate statins, do those new drugs have the same benefit on events that the statins do? And the answer is we don't yet know. There is preliminary data supporting a favorable effect, but actually the magnitude of that favorable effect does not appear to be as great as you'd think it would be based on the incredibly dramatic reduction in LDL cholesterol in response to these drugs. So we still have a lot to learn. And for people who can't tolerate statins and who have very high cholesterols, only those can now be exposed to these new injectable drugs. But the insurance companies really won't support using them for people whose cholesterols are not at very high levels.
Okay, thank you. Now, so I guess kind of the key here is with 50% of us at some point in our lives going to be dealing with some level of cardiovascular disease, and it's probably higher than that when we really break it down, just they died of something else before the cardiovascular disease was what the event was. there's prevention and there's detection, and I work in a field, and I've worked in another field where we talk about internal control, so controlling systems or controlling processes, and a preventative control is typically better than a detective control. But can you kind of get into approaches and things that we could be looking at for early detection or actually what we call primary and secondary prevention?
Yes, I think you've raised a very important question. What is primary prevention and what is secondary prevention? The traditional view has been that primary prevention is the treatment of an individual who has had no history of an event, is not sick, appears to be perfectly healthy, and you want to protect them from developing heart attacks and strokes down the road. That would be called primary prevention. Secondary prevention traditionally has been restricted to people who have already had a heart attack or a stroke, and now your goal is to protect them from a second event. We need a new classification, I believe, because if one carries out some sort of non-invasive testing, which is what we do, and identifies the fact that the arteries are getting blocked up or the arteries are stiffening and they are aging prematurely. And we know that early aging increases the risk for a morbid event during the patient's lifetime. Then perhaps we should call the presence of that accelerated early disease as evidence for disease that requires secondary prevention. And maybe the patient who's already had an event should be undergoing tertiary prevention. That would give us a better handle on what we're trying to accomplish. Because primary prevention is, in general, not using drugs, in general, telling people to alter their diet or their lifestyle. And there's been great hesitancy of applying drug therapy in the absence of already evidence of disease. If we do early detection, and in our center that's an hour testing non-invasively in the laboratory in which we examine the health of the arteries and the heart, and if we find evidence for early disease, then we actually very much encourage the use of drugs under most circumstances because we know from clear-cut clinical trials that these drugs will slow progression and therefore we think will reduce morbid events. And the evidence for that is pretty strong with statins and drugs like ACE inhibitors and angiotensin receptor blockers, which are used to lower blood pressure. So this is where I think our current approach, looking at primary and secondary prevention as the only two alternatives, needs to be expanded to account for the evidence for early disease. Now, one of the ways that people have been encouraged to identify early disease is to undergo a calcium score, which means radiographic measurements that look at the presence of calcium in the coronary arteries of the heart. And there's no question that calcium in those arteries, which can be detected by X-ray, is evidence for atherosclerosis in the coronary arteries and increases risk for heart attacks and strokes. So the presence of that calcium, I guess, would be viewed as evidence for early disease, and treating a person who had high calcium in their coronary arteries could then be called secondary prevention. But it isn't right now. And the problem with calcium in the arteries is it's a very late manifestation of atherosclerosis. It's really an advanced disease at that point, and yet those people are at risk, but I would like to have found them 20 years earlier when they were developing evidence for early disease, when we could have initiated therapy to protect them from getting calcium in their coronary arteries. So there's a difference in emphasis on whether you want to find the disease in its late manifestation or you want to find the disease early when we can intervene and keep people healthy until age 100. And that's been our goal.
Yeah, and I like that. I mean, I tell folks on here all the time. I mean, I think you have to partner with your doctor. You have to be proactive in managing your health. And just because you're not necessarily showing symptoms of a disease doesn't mean it's not happening. It's coming. And so taking the time to get a better understanding, and that's why I really place a lot of value in the book you've written here, because it is a great primer to help someone understand the language, to understand what's going on in their body, and then to basically understand what these therapies can do for us before we're showing or before we have that heart attack or stroke. And so, Doctor, thank you so much for coming on 40 Plus Fitness. If someone wanted to get in touch with you, learn more about the book or buy the book, where would you like for me to send them?
Well, I guess the best place to learn about this is on our website at the University of Minnesota. Our center is called the Rasmussen Center for Cardiovascular Disease Prevention, and we have a website which is identified as cardiovasculardiseaseprevention.org. And so if you go online and to cardiovasculardiseaseprevention.org, you'll find our website, which explains all the things that we do to identify early disease and keep people healthy well into their 9th and 10th decades of life.
Awesome. And I will have that link along with a link to the book in our show notes. This is episode 267. So you can go to 40plusfitnesspodcast.com/267 and you'll find the links there. So again, Dr. Cohn, thank you so much for coming and being part of 40 Plus Fitness.
Well, thank you for having me on the program, Alan, and stay well.
If you enjoyed today's episode, would you please take a moment and go over to iTunes and subscribe, rate, and review the podcast? I'd really appreciate it. It helps others find the podcast and know what we're about. Really do appreciate the ratings and reviews. So if you don't mind going to the iTunes store or through your podcast player of choice and rating and reviewing the show. Thank you. Next time on the 40 Plus Fitness Podcast, we meet Dr. Bob Arnott and discuss his book, The Coffee Lover's Diet. If you like coffee, you're going to love this episode. Until then, have a happy and healthy day.